Here is a piece coming out of a tuberosity. I have a little video from the microscope, just shows us cutting a little piece of tuberosity tissue. You can see how deep the blade goes, so you have a nice deep thickness. And this tuberosity tissue is nice because it's very fibrous. Okay, there are some risks. I tend not to use it in certain areas. For example, in anterior areas for root coverage, there's a risk that sometimes some of this type of tissue can form some sort of like a cleoid formation where it can actually grow like a growth and thicken over time. So with these, I tend to use it around implants only, especially just around the tissue in the papilla region, because it can plump up the papillas, but not for root coverage as much for anterior teeth. I use it in other areas, posterior teeth, because I don't mind, around molars it doesn't show. If you get a nice thick bulgy chunk of tissue, no one cares. It's nice and healthy and stable. But for any aesthetic areas or a patient who's very aesthetically inclined or picky, I wouldn't use this tissue. Okay? So you can see, you just basically take a little slot of tissue, 1 or 2 stitches to close up that site. They hardly even know. Now this is usually a thick chunk of tissue. You can actually cut this in half and fillet it out into like 2 pieces and open it up, and you have enough to graft at least 2 teeth. Easy place to get a tissue graft when you need it. Especially, I like these areas, especially for my implant case. And then the retromolar pad. So retromolar pad, this is lower wisdom teeth area. You can see here, sometimes you have a nice thick chunk of tissue, not as fibrous as the tuberosity, but you get a good decent amount. Okay, here is our area. You can see I'm taking out a piece, and that piece is deepithelialized, and then I sort of fillet it in half, leave it still attached, and kind of open it up, and you can get a nice long strip of tissue. So you can see there's enough connective tissue there to graft 2 teeth. And so this is another very easy area to get tissue. Patient doesn't feel any pain or discomfort, and they're quite happy. And then here is the last 5th area. Remember I mentioned that there's buccal gingiva. So this was a small mini free gingival graft that we got from a thick area where buccal gingiva. So here you can take it right off the buccal gingiva. As long as you're doing a split thickness and not exposing bone, you're safe. And again, this graft was used to graft a small little anterior 3-1 lower anterior tooth that had a small mucogingival defect. So with this, we basically transplanted the graft right next, and the donor side, they were basically side by side. The patient was thrilled. They're like, oh, it hardly even hurt, just a little bit of tenderness for a few days, and it was fine. So there's lots of options in the mouth to get graft. And when you have all these options, you'll see as you get comfortable, there's a very not much need for manufactured donor products for grafting. So basically, again, treatment goals: we want to have a wider band of attached keratinized tissue for health. We want to get root coverage. You want to get both of them and increase the thickness. And you want to sometimes also eliminate the muscle pull, which is a frenal attachment, with additional wider tissue, and recreate vestibular depth. So these are all our things that we do with tissue grafts. And lastly, improve aesthetics. Everything is about aesthetics with me. So to make it simple, free gingival grafts are gold standard for increasing keratinized tissue. If your goal is only to increase the band of attached tissue, then a free gingival graft is what you want to do. Connective tissue grafts are usually good for root coverage. So if you want to cover a root and expose it and have it look a little bit more natural, then you want to do a coronally positioned flap with a connective tissue graft. Now, whenever we do these procedures, soft tissue grafting, you have to be it takes a lot of fine movement and fine motor skill, and you have to be gentle with the tissue. So we usually use a microsurgical approach because we want to use smaller instruments, smaller sutures, less trauma to the tissues, which will give you better results and better healing. So smaller incisions, create preservation of blood supply. If you use magnification or a microscope or loops, it improves your visualization. This allows you to then bring tissues and close them back together nicely, which allows the healing to go faster. There's less pain, and if you have less pain, then you have a happy patient. So instrumentation, I won't go into too much detail with this because this is only a 1-hour webinar and I can't teach a full course out of this, but instrumentation, basically, if you're going to do soft tissue grafts, I want you to really invest in a good needle holder and a good tissue forceps. These are key because soft tissue grafting is very difficult in the sense that it's fine motor skills, and if you don't have good equipment, you will not be able to perform well. And it won't be because of your skill, because you have shitty, cheap equipment. So if you're going to start doing soft tissue grafting, don't buy the cheap $100 needle holder. Buy the $400, $500, $600 one, because you'll just see the difference. They last longer, they have better control, better movement, and it just works better. And you'll even notice after using the better one that it's worth it. For a $600 needle holder, if you're going to do even one tissue graft a month, it's going to pay for itself. And especially if you're using a good quality one, your time will be better. You'll have better predictability. You'll be more efficient. So your money's made that way. Don't be cheap. It's one of those. It's a pet peeve of mine when someone will buy a cheaper $50, $100 cheap knockoff stainless steel needle holder that pretty much is like a hemostat. Invest in you're providing. If you want to do something well, you have to do it with the right equipment. Like, for example, you're not going to win, Formula One with a shitty car. They put a lot of money and investment in fine tuning their engines to make sure that they're perfect. So same thing. This is your equipment. This is your car. You got to take care of it. And you got to use good equipment to have good results. And sutures too. We'll talk a little bit about sutures. I'll go over that in a second. But with regards to blades, I use mainly a 12 blade, 15C, and a 15 blade mainly. 15 blade I use mainly for harvesting tissue because of a wider and smoother cutting edge. A 15 is nicer because it's smaller. A 15C, is nicer, which is shown here above, which is nice to get around narrow teeth. Sometimes I use small micro blades, like these ones. These are crescent knives. These are ophthalmic blades for eye surgery, but they're really nice to fit right into small areas, especially lower anterior teeth. If you have very thin tissue and you want to dissect around it, these are perfect to go around the sulcus. These are different microsurgical knife too. There's a little Nordland knife too. These are good also, especially when I'm doing lingual cases, lingual lower anteriors. I like these knives because they just get in and you can actually bend them and shape them. These are our other sort of, they're gingival knives, but they're meant to be used as tunneling instruments. So these are part of our tunneling kit, which are used to go in and dissect out the periosteum from internally. These are all different types of tunneling instruments. You can see they come in different angles and shapes and stuff. So anything that can kind of get you through the sulcus and manipulate the tissue. Every time I see a new instrument that has a different angle, I'll pick it up because it's one more different addition to my set here, which will give me better access. If we zoom in, a little closer, they come in different sizes and different heads, so you can kind of get in and strip. These are again used for tunneling. They'll allow you to easily strip in and through and lift the tissues. Again, like I said, invest in your instruments because you'll do a better job if you have a good instrument. And then sutures. So as a general rule, when I'm doing soft tissue graft or soft tissue grafting, I will only use a monofilament suture. So monofilaments are things like monocryl, glycolon, proline, nylon, things like that. I don't use braided. I use vicryl, but I only use a 7/0 vicryl, and it's only used to secure a graft in sight because it's resorbable and it's buried underneath. These other monofilament sutures are not resorbable, so I tend to leave these on the surface. But again, a monofilament suture is very tissue friendly, doesn't create an inflammatory reaction. I'm a big fan of proline. They are more expensive, these sutures, but you can't compare this to the others. When you look at before and after at your first post-op check, you will see that it's worth every penny. If you need to charge more for, add another $10, $20 to your procedure so you can use better materials. Okay, so now I've been talking for a while about details like that, so let's see some cases, okay? I'm going to kind of go through some of these quickly just so you can see some of the type of work that we do and what's available and what can be done with soft tissue grafting. So our first few cases are going to be about increasing keratinized tissue. So here we have a case. You can see, again, you can see black triangles of the papilla, so that means that root coverage is not predictable. You can see thin tissue. There's recession, but as well, there's no attached or even no keratinized tissue in the 4 anterior teeth, okay? And so our goal here is to get that thick band of tissue because we want to keep these teeth, they have bone loss, so we want to keep them healthy and stable. So here, it's obvious, a free gingival graft is an indication for treatment here because I know a free gingival graft will basically get me what I need. I told the guy, here's a graft suture. I told him that, you know what, our goal is to get thick tissue. You want to keep your teeth healthy and stable. We're not worried about root coverage. Whatever happens, happens. This specific suture design is one of my own. It's, you know, numerous people have helped me name it. I don't really have a name. We call it a net suture, but it's an interlocking continuous suture that will hold the graft and compress it against the recipient bed at the same time. So we use this suture. The graft is at 2 weeks. This, as you can see, it's incorporating nicely. There's nice pink tissue. There is no mucosa. Another thing to note is that margins are evened out. This is it after a few weeks after the graft is matured. So now we have a nice thick band of tissue. You can see now the gingival margins have evened out. So we did get some root coverage and things look much better aesthetically and from a health point. So if we see the before and after, you can see there, we've got nice, healthy, thick tissue. Now, despite having bone loss and despite being class 3, possibly Miller defect, we got some root coverage and we've improved the health and the aesthetics. So from this, we've given these teeth a better longevity, better prognosis, and you can see now even they're more resistant to inflammation and easier to keep healthy and clean. Here's our next case, same thing. This lady actually had lichen planus, and so with the lichen planus, plaque control became difficult. She had minimal to no keratinized tissue around these implants. There's the frenal attachment that you can see right there, and then literally no keratinized tissue here. You can see the redness and the plaque. This is just because of the lichen planus and discomfort. So hygiene was an issue. So you can see here again, plaque buildup. So here, again, the free gingival graft was meant to improve the health of the implants, protect them, protect the bone, as well as improve home care and hygiene in the area. Here's our strip free gingival graft, harvested from the palate. The graft is then secured on a split thickness bed. It's sutured, and then given good adaptation against the recipient bed to get blood supply, because these are free gingival grafts, they only get their blood supply from the base. And this is after healing. So you can see now there's a thick band of tissue. It's attached, it's more pinker and healthier. It's easier to control hygiene. Now she can brush her teeth a little bit better. Her hygiene is still lacking, but it's improved the condition, and this will improve the health of the teeth. And so like this, we've improved and protected the implant and, give them a chance to at least not have worse issues or periodontitis and bone loss. Here's a case. Now this patient, we had done a GBR on them, and when they did the GBR, we repositioned the mucogingival junction to cover the graft. And what ended up happening is that now the mucogingival junction, the mucosa, came all the way out to on the ridge almost. And so prior to placing implants, we wanted to recreate that vestibular depth and increase the band of keratinized tissue. And so we did this using a free gingival graft. Here's our free gingival graft. The graft is sutured and secured on a split thickness recipient bed. So you can see the flap is split, and then the flap itself is apically positioned and secured with chromic cut sutures up here to open up that vestibule. And then our graft is then placed over where we want the keratinized tissue. And this is that net suture I was talking about, was secured and sutured in place. And you can see here a little bit of Surgicel, which is where we got our donor graft from, just from the other side of the palate. And once it healed, this is what it looks like. So now we have a nice wide zone of keratinized tissue. The implants can be easily placed, and you can see the before and after. It's a huge difference. So now the patient's ready to proceed with the implants. In this case, I only did the bone grafting and the soft tissue grafting. The dentist was going to be placing the implant, so I had to get everything ready for him. Sometimes these steps can be done at the time of implant placement or recovery. And so, because I wasn't doing the implants, we did it ahead of time just to prepare the site for the referring dentist so that he could have no issues placing his implants. Lastly, here's another case. You can see very tight contacts, existing history of bone loss, no keratinized tissue, shallow vestibule. So what we do is we create a split thickness recipient bed. Our goal here, again, is just to get a nice band of keratinized tissue. I take a long strip of keratinized tissue from the palate. Here is our graft. The graft is thin. You can see it's not very thick. A nice thin graft, long strip, is then positioned over the area. It's secured on each side. And then we have our net suture to hold it in place. Position it tightly against the recipient bed. And once everything heals and matures, here's the final result. So here again, Root coverage was not our issue, wasn't our goal. We just wanted a thicker band of keratinized tissue to thicken the area and get an improved prognosis for these teeth. Here is the before and after. Everything looks much healthier, much nicer, and now we know that although there is some bone loss around these teeth, their prognosis has improved because of the thick attached keratinized tissue. Whereas if we left it alone previously, the recession and bone loss may have proceeded or progressed over time. So our next type of technique is our coronally positioned flap. So here now root coverage is what we're trying to do. So here you can see in this case here, we've got two central incisors. You can see that the papilla fill is good, but there's no keratinized tissue on the anterior teeth. So here, tissue is very thin, so we have to be careful. Here we did a coronally positioned flap with vertical incisions. You can see the flap. It's made here, but doesn't really show in the picture. Here's part of the flap. We took a connective tissue graft and secured it over the root, and then the flap existing goes over the graft, completely burying everything and closing it up. We have a sling suture that wraps around the teeth, holding it in place. And then we have interrupted sutures along the vertical incision lines here. And then here you don't see it, but I've put a vestibular apical mattress suture that kind of takes away the tension from the lip, giving the graft some space and some time in the flap to be able to heal without so much pull. There's a closer view of that apically positioned. It's basically an apical mattress suture. Okay, and it just kind of holds the graft in, takes away some of the tension from up here, allowing the root coverage to be more predictable. Here is the result. We have nice root coverage. We have also a nice thicker band of attached tissue. Here it is a little bit long term. I think this was after a year or so we saw her. She came in, looks good. A little bit of inflammation in the papillas, but overall root coverage and thick attached keratinized tissue look good. So we can see from before and after, we've got our band of attached keratinized tissue as well as root coverage achieved. And so now the environment and everything, stability of the teeth and everything is much more healthier from where she started off. Our next case here, a couple of things to know. A little bit of recession. The recession, not a huge thing. Thin tissue here, not much attached tissue here. We have a nice buccal frenum here that's pulling and causing some of the mild recession. So here with this, we use a connective tissue graft harvested from the palate. We use a split thickness graft, split thickness buccal envelope flap. Here, what I do is I don't cut the frenum from the outside. Where I do my periostal scoring internally in the flap, I separate the frenum so that it starts to travel more apically as I stretch the flap to cover the roots. The graft is then placed into the flap. Now, in this case, I did something a little bit different. Rather than securing the graft along and around the roots, I secured the graft to the flap. And then I coronally position the flap with sling sutures to hold it in place. So you can do it either way. They both work. The way to do it the other way, where you secure it to the teeth, is in case the flap retracts, then you may lose the graft as well if it's attached to the flap. Whereas if it's all done in separate layers, then you have a second layer as a backup. Now I want you to notice that, remember the pre-op where the frenum is, and look at it now. Because we were to strip and stretch the flap, it allowed apical displacement of the buccal frenum without even having to cut it. Okay, and you'll see, so here's the healing. So remember that it was much higher and now it's been pushed a little bit lower. It was up here. This is right after, and then long-term healing. And see before and after. Okay, so here you can see without even having to do a frenectomy, we were able to apically displace it by stretching the tissue through our periosteal release and doing the procedure. So now root coverage has been achieved, there's thicker attached tissue, and the frenum has been addressed. So now I want to talk about tunneling approaches. Tunneling approaches are usually in more aesthetic areas. The reason being is because when a tunnel graft heals, it's almost hard to tell anything was done, which people really like. And so I'm a big fan of the procedure. It's a little bit more technical, but it works really well when you choose it in the right indication. Now what tunneling is basically we strip the tissue off the bone without having to cut anything. So it's all done through the sulcus. So here in this video, you can see this flap is tunneled and released without having to actually make any cuts, because everything is done through the sulcus, and So once this is done, then we slide the graft in through this pouch and tunnel, and then with sutures we sling and push position everything currently. Here is a simple tunneling case. You can see the recession, minimal attached keratinized tissue, complete papilla filler, prominent root. Here is our graft. The tunnel is created. The graft is then inserted into the tunnel through the sulcus. It's secured with 2 sutures. So first I usually secure the graft so it's in position where I want it, and then a sling suture will then currently position the flap with the graft higher up on the tooth. And what happens is as it heals, it attaches to the correct level and the recession is gone. And so here we have our before and after. We've addressed the root coverage, which is the primary concern, and we have a good result. And this is very predictable and quite easy. Here's another case. Again, you can see slight recession on this area. The root surface is scaled and clean. I usually use a scaler and a back action chisel, because the back action chisel can clean the surface and fits really nicely on the root surface. This is a gingivectomy knife to make my first incision through the sulcus, and then a tunneling knife to go in and strip the tissue. Here's our nice little connective tissue graft. So you see, we don't even need a large graft. A small graft is perfect, just enough for this little site. And remember, this is a central incisor, so this graft is literally about probably 10 millimeters wide. You can see our instruments are going in through the gums. Once a tunnel is created, released everything, meaning that it's scored the periosteum underneath to allow the flap to be currently positioned. Here is our graft going into the tunnel. It's secured on one side and then secured on the other, and with a continuous sling, everything is brought down more apically. At 2 weeks post-op, this is what it looks like. So you can see how nicely the tissues heal around these sutures. There's very minimal inflammation. Things are looking good. Sutures are removed. And this is a little bit more long-term. You can see the tissue graft and everything's healing. So we go from before and after with a nice result. Our next case here is a couple of things going on. One, we've got a little bit of spacing. She's going to be going through some orthodontic treatment. We've got a shallow vestibule, frenal pull, no attached keratinized tissue. So in this case, we wanted to address everything in one procedure. So normally something like this, we would do it in 2, where I may do a free gingival graft first and then currently position it. But due to her time constraints and trying to go through one, we decided to do it in 1. So I had to do a little bit of a modification of what I do. So first I created our tunnel. The graft is then taken. I use a larger graft so that it gets blood supply from the neighboring areas. Secured it in place. It's all slid in through the same sulcus. And then what I did was I currently positioned it, left a little collar of the graft exposed to get keratinized tissue, and then at the base I made an incision to apically release that frenum, and then I secured the segment of the graft and the flap with an apical mattress. So now anything that pulls on the lip will not pull this. So this secures and recreates that vestibular space, keeps our graft and our site secure and separated from the pull and tension from the lip and the vestibule, and allows us to be able to get predictable root coverage in one procedure. So this is at 2 weeks at the post-op. You can see how nicely it's already, you can see the vestibular depth has been recreated, how fast this incision heals. You can see how the tissues look around there. And then once everything is healed, now when you look at this case, you can hardly tell that anything was done. If I show you before and after, you see she's had her ortho, everything is done. You wouldn't be able to tell if I told you that the person on the right picture had a graft done. And so you can get really, really nice results with tunneling. Even the vestibular incision doesn't even show. So we've recreated that vestibular depth. The gums and everything look perfect, thicker, healthier, and stable. And this is what we want with tunneling. Here's another case, smaller defect. You can see a little bit of a mucogingival defect and lack of keratinized tissue. We used a tunnel approach. Here's our graft. This was taken on a glass slide. That's why you see the blue. This is some artistic photography, just to wake everyone up. So here's our graft. We use a long strip graft because I want to also thicken the tissue around the area. So the graft is then inserted in through the sulcus. It's secured in place. I have 3 sutures securing it to the right place. And you can see how we've kind of kept it right where we want it. And then with sling sutures, everything is currently positioned and held to the right level so that we can get root coverage as well. This is the case at 2 weeks at the first post-op appointment. You can see the sutures and everything, how nicely everything heals around these sutures. There's very minimal inflammation and the tissue heals very fast because these are prolene sutures. And then once it's matured, this is how it looks. So again, another case, it looks like very hard to tell that any grafting was done. Now you can see the before and after. We had minimal recession, which was taken care of. The tooth is buccally positioned, so that's why it looks slightly longer, but there's no actual recession. It's just the positioning of it. But now you can see the tissue is healthier around the area, and it's also thicker, especially around the other central incisor as well. And so we've improved the environment, we've thickened the tissue, we've taken care of the root coverage, and things are healthier and look better too. Our next case here, again, this case, when I saw this lady, if you see the next slide, I told her that, what, I don't know if I'll get the root coverage because unless you're considering orthodontic treatment, these teeth are very buccally positioned. If I even cover it, it'll look good, but I can't promise it'll stay. So she said, okay, let's do it. Scaled and cleaned the root surfaces, rinsed them with saline, did a tissue graft through the tunnel, secured it with sutures, apically positioned it. In this case, what I did is I did basically 2 sutures to secure the graft, 2 separate sling sutures, and then 2 separate apical mattress sutures to really hold this segment and fragment down. And this is her at the 2-week post-op. Things are looking good. Tissue looks really nice, ready to have the sutures removed. This is the same day I just removed the sutures as things matured. And this is how it looks. And I saw her 5 years post-op, and this picture's 5 years post-op now, before and after, and it's still there. And she's like, look, you told me it wouldn't stay. And she came and she's like, look, I just want to show you it stayed. So it looks good. So things are looking good. It's healthy. It's aesthetic. Patient is happy. I'm happy. Another case here. Simple recession. This is, I think there was attached. So it's kind of a combination. I think the lateral is a class 2 and the canine is a class 1 Miller defect. Use the tunnel approach. Here's our connective tissue graft. Graft is stuffed into the tunnel, secured, sling sutures chronally positioned. At 2 weeks, this is the 2-week post-op where I remove the stitches, the sutures. And then this is the final result. Tissue looks nice and clean and healthy, nice and pink. When you look at it, you can't even tell that any treatment was done, which is what our goal is with tunneling. We want to make sure that everything stays healthy and there's no issues and it looks good, the tissues are thick and aesthetic, and the patient is happy. So now our last section, because I've just shown a lot of variety of cases. So our next section, apart from going to a whole area of implants, that could be like a whole nother lecture, but usually sometimes for aesthetic areas, if I can't place the implant at the same time, I tend to like to seal the socket with some tissue to keep the support for the papilla, and I don't want things to collapse. So this is where socket sealing grafts come in. So here we had a tooth, because of the way the fracture and the position was, an immediate implant wasn't ideal in this case, so we had to do it staged. So the tooth was removed, the site was grafted, and then what we want to do is put a tissue graft because I wanted to support and keep these papillas in place. So a diamond burr just goes in and just removes the epithelium from around the sulcus so that we get a bleeding surface that can feed our graft. We take a punch graft. These are the only grafts that I take that are quite thick. We want something nice and thick so that it can get its blood supply from the walls of the graft. The graft is then just put over the socket, measured and shaped in place, and then secured. And here we use these micro sutures. These are reef knots used to secure the graft in place so that it pulls it against the walls of the sulcus to get blood supply. And this is how it heals. So you can see how the graft is matured and healed nicely. There's a coronal portion. So we have all this tissue now that will then be used to shape the papillas and the tissues and keep that position when we do the implant and provisionalize. Okay, so this is another way we can use soft tissue grafts through these socket seal procedures. So they can be done through these punch grafts, or the other way it can be done is through the pedicle graft, so that connective tissue pedicle graft that I had shown in the little video earlier. So here, same thing, lateral tooth. It was fractured, so we had to remove it. Again, because of positioning, we couldn't do an immediate implant. and due to bone loss and other things. So this had no buccal plate as well, so I had to stuff in a stiff collagen membrane to create a buccal wall. We grafted the site and then used a pedicle connective tissue graft. And it basically comes from the palate, it's attached. It slides. I make a small incision so I can go in and through over the sulcus or over the socket, seal the socket, and get tucked into the buccal. Okay, so here it is being pulled from the palate. I slide it from the palate portion, goes through over the socket, and gets tucked into the buccal portion. And then it's secured with the suture. So from a coronal view or an occlusal view, here's what it looks like. So you can see here, the graft is taken from the single incision here. And then what I do, because this is a socket, I make an incision here, and then I undermine this tissue bridge, and I slide the graft from here underneath this tissue bridge over the socket, and then tuck into the buccal and secure. And then we just close this with sutures. And so quite, easy to do. It seals the socket nicely. Very safe and comfortable for the patient. It doesn't hurt them at all. Now this will allow us to keep our nice tissue contour. This is the patient at the 2-week follow-up. You can see the tissues are still there. The graft is surviving. And then once it's healed, so you can see now we have a nice robust thick amount of tissue. It sealed the site so we didn't lose any particles from our socket preservation, our socket graft. And we have nice thick healthy tissue, which will make the implant placement through a punch incision if needed very easy. And it also allows to have all the extra tissue to provisionalize. Okay, so that brings us to the end of my quick webinar today. Sorry I seem to kind of zoom through a lot because there's just so much content that you can do with tissue grafts, and each section alone can be a whole lecture on its own. So this was just a brief overview or shot of what you can do with soft tissue, and there's still a whole plethora of other things with implants and GBR that we didn't really get into. All right, guys, as promised at the end of my webinar here, I promised you guys a special announcement. So for today, our special announcement, we'd like to introduce our new STG online program. So this is basically a soft tissue grafting program. It's online and it's made specifically